All this is Dr. Mobeen Syed from drbeen.com. Welcome to one more show. So some of the cool beans said that we have reign of rock stars at Dr. Bean. So here we have a rock star back with us once more, Dr. Darrell DeMello from India. I can only imagine the service that he has done and the blessings that he have collected for serving the humanity. And not only then he's serving the humanity successfully at this time, he is then sharing his knowledge as well, his experience as well. So the other healthcare professionals, other healthcare workers can understand how to manage. And for patients, it is a good guide as well. So with this, Dr. DeMello, welcome.
Thank you, Mobeen. Great to be with you again. It's always a pleasure.
Excellent. Thank you very much. So tell me this, from last time till now, how are things? I'm going to show India's chart in a second. What is your experience? What is your observation at your clinic?
From last time, from the first time, we did the first one in June to now, we have really gone down. I'm doing 2 to 4 cases a day, new cases. And I'm doing post-COVID cases. I'm talking about acute COVID cases, new cases are 2 to 4 a day. But I'm getting a lot of post-COVID cases, both post-acute COVID and post, when I say post-acute, meaning post 15 days and then post 1 month. So I'm getting a lot of those cases now, and India has really come down. At one time, we were in that 40, 50,000 cases a day, new cases. Now we are somewhere in the 25,000 cases a day, and places like Bombay City, Mumbai City, Delhi City have come down to 200 and 400 cases a day, new cases. And deaths are basically non-existent. So 2 deaths, 4 deaths, really nothing. And it's kind of it's come down drastically. It's a great news that people are getting COVID, but they're getting it in a milder fashion. And I think many of the family doctors, general practitioners, MD physicians who practice have actually learned how to treat the disease finally. And that has really helped take care of all the bad things with India. And so, the government efforts also, I must applaud for all the support and all the stuff that the state governments and the national government has given us and has allowed us to treat this disease the way it should be treated. But it's been phenomenal to see that come down to almost non-existent. Mobeen?
Excellent. And I totally love this. And this is very interesting. So the case of India, for all of us, wherever we are, I am here in the US. Remember, I practice in Pakistan. I don't practice in the US. But I'm here in US. And if you look at US cases, they are just soaring. And we don't have this kind of a success. But generally, without criticizing any country, it is interesting to see how physicians in various parts of the world, they focused on the problem. They had it's a pandemic. The whole world is stuck in it. So physicians had to find ways, and physicians like Darrell here, they are the ones who broke ground, who brought us forward to understand these are the messages that are going to go in the books at some point to say there was a pandemic, there was a virus caused, here is the pathology, here is the damage, and here are various physicians and the way they managed, and here were the successful managements, and here some of the not successful managements. So I think that is how it would evolve further. So Darrell, once again, thank you very much for your work.
Thank you, sir. And let me just add a few things, Mobeen, to this. One is, like I've always said, I've said this from May last year when I first started treating, that this is an inflammatory disease causing clotting. Okay, not just a pure viral disease. The virus, to me, is a terrorist. It's only a stimulant. It's an irritant. So that classical approach of saying this is a viral disease and the only thing that's going to work is a vaccine and nothing else, that I think some of us have disproved. And eventually you saw that downward slope. I think because the rest of the physician population caught up with the fact that this is an inflammatory disease. So we saw a lot of steroid usage. We saw a lot of usage of anti-clotting drugs, aggressive usage of things like low molecular weight heparin, which is enoxaparin, and we saw usage of ivermectin everywhere. So it's a multi-pronged approach to this disease. It's not a one thing. So the difference between treating COVID and treating a regular viral disease is we are trying to treat the effects of the body's super surge, a super overdrive of the body's immune response system, what you and I would call the cytokine storm. I liken it to a tsunami. We are trying to fix the bad effects of that tsunami. Okay, so we're trying to really fix those problems. We can't fix the earthquake in the sea, but we can actually fix the problems of the tsunami in advance. And by using drugs like colchicine or steroids, you can actually start preventing that. And my success with colchicine has been phenomenal. I'm really humbled and honored and stunned by the success I've had using colchicine. We'll talk about colchicine in more detail, and I'll kind of explain to your listeners, to the cool beans, as to why I chose colchicine and why I went with it. Okay, Corbin?
Excellent. Thank you very much. And for the cool beans, as we are talking about the cool beans right now, the structure for today's program is the following. We're going to go further in depth with the discussion of how India is doing, what is the impact of the vaccines, and as you just heard about the impact of the physicians who are learning various ways to work. Then the second important part that I want to do is digging deeper, 5-10 minutes, into colchicine and how colchicine works and what is the observations of Darrell on that. After that, we would start taking your questions. We have some questions on Twitter as well. And this time, I promise we'll take more questions from YouTube as well. Every time we stay a little thirsty, this time we're going to give more time on the questions. So please hold on to your questions for another 10-15 minutes while we go through this discussion, and then we'll come back to you. So, sorry. Yes, go ahead.
Mobin, I just want to say one more thing. This is not quercetin. Quer, this is not that. This is colchicine, Colchicine. This is the drug. Fantastic drug. I can talk a lot about it later when we talk. So it's no problem with that. Okay.
So how about we do this? We are at that point. So the discussion's primary focus today is how Dr. DeMello has been using colchicine successfully in helping COVID patients. Now, please remember, when somebody is a patient, COVID or any other patient, there are symptoms, there are inflammation, there are things that are happening in the body that can use drugs other than just the vaccines. Vaccines are actually not useful when somebody is going through the acute infection. So here we are talking with the doctor who is going to discuss what do they do when somebody is in the acute disease phase. So Dr. DeMello, Darrell, please tell us about colchicine, your experience, and this is your presentation. Please tell me, help us understand.
Right. This drug colchicine is one of the oldest remedies still in use today. It's derived from the bulb-like corms of the Colchicum autumnale plant, also known as autumn crocus. Its history is it's a herbal remedy for joint pain, goes back at least to 1500 BC, and the active ingredient is colchicine, what we're going to talk about. Okay, so it was approved in the US. It was isolated in the early 1800s and remains today as a purified natural product. Approved in the US in 2009 for gout. The reason I went with this drug, I was looking for something close to tocilizumab, something that really worked on the basis of getting to stifle or reduce the inflammation, especially interleukin 6, interleukin 1, 1A, and some of the other interleukins. This drug does that at a fraction of the cost of what tocilizumab does. So that's why I picked it. I looked at lots of anti-inflammatory drugs, including steroids. And I use steroids as a secondary measure. And I always, when I talk, I always joke and say, this is my target bombing rather than the carpet bombing. So this is a sniper-like attack where I'm going in for specific reasons to reduce the interleukin 6 versus doing the carpet bombing that we do with, whether it's methylprednisolone or whether it's dexamethasone. With steroids and high-dose steroids, we are actually bombing everything. We are reducing the immunity as a general immune suppressant. Why does COVID work? Let's go to the next slide for me. And it prevents thrombosis. So let's talk about that, okay? So thrombosis in vessels occur due to multiple factors. Inflammation is the most common. Inflammation activates thrombosis through tissue factor internal cascade of coagulation. The tissue factor, when exposed to blood, interacts with factor 7A to activate the factor 10A, which is the key activator of thrombin. Now let's talk about tumor necrosis factor. Tumor necrosis factor is a key. Yeah.
Darrell, just my quick interjection, my apologies. There are some comments that can we make it full screen. So guys, before this discussion, we actually did a rehearsal to make it full screen and it hung my computer. So I think this screen sharing software and the full screen here, somehow they fight with each other. And when I came out of full screen to discuss other things, it hung. So please, my apologies, let's just use it in this state. Otherwise it might get hung again. Darrell, back to you.
Yeah, let's go back to tumor necrosis factor. Tumor necrosis factor is a key inflammatory marker that induces the monocytes. So I always look for monocytes. What is the level of monocytes? Anything that you see above the normal, above 7 or 8 or 10, I've seen up to 15 and 16% of monocytes, okay? And on the alternative, you see lymphocytes down to 4% and 5%, okay? So that tells you something. So this marker induces monocytes to produce the tissue factor inside the blood vessels. Once you've activated the monocytes producing plenty of tissue factor, you will see intravascular thrombosis. So this is what leads to thrombosis, okay? So colchicine is a potent inhibitor of tumor necrosis factor alpha or A, thus prevents the activation of the monocytes. So if you stop that activation of monocytes, you can actually stop the clotting or stop the thrombosis. And whether it's microvascular or big vascular or macrovascular, it doesn't matter. Clotting is clotting. People have died of heart attacks because they've had the soft plaque in the arteries. When the autopsy was done, they found soft plaque in the arteries. The artery clotted off. So these are things that happen in COVID. And lungs, COVID in particular, like I always say, is a diverse thing. There's one that hits the lungs, one type of COVID that hits the lungs, and one type of COVID that hits the general constitution. So you're looking at central nervous system, you're looking at heart, you're looking at all the other microvascular issues across the body. And you have liver enzyme raised quite significantly. Okay, so let's go to the next slide, Mobin. So colchicine now prevents tubulin formation inside the neutrophil, which is needed for neutrophils to migrate to the site of inflammation. So where's that inflammation happening? When the virus comes into your nose, goes into your throat, goes into the lungs, the body's going to react. It's going to react pretty aggressively. So if you can these neutrophils will start migrating there to attack the agent that's causing that inflammation. So we are trying to reduce that, okay? So in many inflammatory diseases, neutrophils are the pivotal cells involved. The neutrophils participate in inflammation. Their participation in inflammation depends upon their ability to migrate towards the damaged or stimulated tissues. Since neutrophil migration is affected by microtubules, the interaction between colchicine and tubulin distorts this capability, thus suppressing the inflammatory process. You want to explain this a little bit more, Mobin, for me? I mean, you're the teacher.
Thank you very much. So I think the important thing from the Cool Beans point of view, we have been talking about monocytes and innate arm as well. Monocyte is more towards the innate arms macrophage side, and neutrophils are more, remember those irresponsible friends I've been talking about who would chew up something and then throw it out, and that in that process they help with the inflammation. And monocyte, I think with Dr. Bruce Patterson's research as well, you know that monocytes can get mad in cytokine during the COVID, not just for the cytokine storm, even for long haul. So both of those cells are actually very, very much involved in this one. And I love it that here, since neutrophil migration is affected by microtubules. So this is, my apologies, Darrell. I mean, you've done a great job. Its mechanisms are just my favorite. So imagine within the cell, there are microtubules or fingers of the cell that are inside the cell. And then they push the cell to one side. And as the cell moves or rolls towards the side, they're pushing from inside. Then the other microtubules on the back side of the cell are dismantled, brought to the front again, and then more fingers are made. It is just a beautiful mechanism where cell is actively dismantling the microtubules and making the microtubules and walking with them. And colchicine would come in and just block that process, and cell would freeze in its place. That's a beautiful mechanism. Back to you, Darrell.
I actually asked a pharmacologist, a head of clinical research of one of the big hospital chains, to help me understand from the scientific side, how does this really work? And he gave me this whole write-up. And this is way back in May last year, May, June. So I was confident about the science part of it. I also got success with the clinical side of it, and I just stayed with it. So almost 100% of patients have got colchicine unless they have other problems like kidney issues or something. Even kidney issues, I've had 30 kidney failure patients where I had to titrate the dose down to once every alternate day for them, 3 times a week. And they ended up with asymptomatic COVID, and antibody tested positive, in December, January, February, before the vaccines came in, and they were fine. So it's all about knowing what you're doing, both clinically and science from the scientifically. Okay, so I did do my science homework before I went wild with colchicine, but this is one reason why I stayed with colchicine in everything I do, not just in acute COVID, but in prophylaxis, in acute COVID, in post-COVID, and long-haul COVID. This is the baseline drug that will help everybody in the world to recover from COVID. If this is not, again, I'm not talking about the virus here. The virus, I use ivermectin for 2 days. 2 doses a day, 12 milligrams, 2 days, over. Okay? It's about stopping the whole inflammatory process, stopping the inflammatory process from leading to thrombosis. And that is the reason why I think I've been successful with this whole thing. Moving. Next slide.
This is such an excellent thing that, and please, I want to keep clearing it up for the folks, for the audience. It is not really that you're asking a drug to go kill the virus. That is a different thing. Here, the virus has affected the body, and the symptoms are telling that there is damage and inflammation. And there are drugs, for example, there is steroid that can help with that. Ivermectin is an anti-inflammatory. There are other anti-inflammatories. Colchicine is also an anti-inflammatory, and it suppresses the chemotaxis as well. So this is a beautiful product too. So sorry, back to you. I just cannot hold my excitement about the mechanism discussion.
Yeah. And I must thank Dr. Sigamani, Albin Sigamani, for having put this together for me. And every time I've had a underlying science, why does this work? I see something I do, whether I use vitamin D and iron together, whatever, I would go back to him and say, Albin, why does this work? And he'd give me the whole write-up for why it works. It gave me more confidence, because when you have success and you're seeing success with something you're using, you really want to use the drug that is going to help you. And you got to understand why it works. If you understand why it works, it's very easy to continue using it. So this is why I didn't try many other drugs. Everybody in the world has asked me, why are you staying with the drugs you first used? Because I've had success. I don't give 15 different drugs or 10 different drugs. So let us just stay with what we have. You don't change a winning team. If you have a winning team, stay with it, make it successful. Okay, let's go back to colchicine. Endothelial cells play an important role in neutrophil transmigration towards the inflammatory site. So they're going to travel. Okay, the neutrophils are going to travel. Colchicine can alter that distribution of the adhesion molecules on these cells. So further inhibiting the inflammation inside the vessels, which triggers the tissue factor and the entire internal cascade of coagulation. So we are stopping the whole cascade of coagulation. Okay. See, remember, if you go very high inflammation, you're going to set off the cascade of coagulation. We are stopping that migration. We are stopping it with colchicine. This is one reason why I think I've been successful, and many of the Indian doctors have been successful, because many of them have started using colchicine as the baseline anti-inflammatory, in addition to steroids. I use steroids later. I use steroids on day 8, 9, or 10 if I need to. If the patient's stable, I'm not worried about using steroids. My steroid usage in the first 3,000 cases was 7%. In the next 4, 5, 6,000 patients, I've had usage of probably about 15% or 20% of cases. So for me, I've had to, because I get really bad cases now. I get really bad cases where I have to use dexamethasone as my steroid of choice. I have to use it to take care of stuff. But this is why colchicine works. I can talk and talk and talk. Colchicine has been a fantastic anti-inflammatory in COVID to stop that cascade of coagulation. Remember, we are trying to stop the coagulation. We're trying to stop the clotting. Then, of course, I also would use a drug called clopidogrel to make sure I'm really cutting down on the bounce back in platelet count. Because I would see a platelet count decrease to 70, 80, 90,000, 110,000, go back up to 750,000 that I have seen, anywhere between 450 and 750. That means that there's adhesion. High platelet count means it can start clotting. So again, I'm doing both things together. Movin, take next slide.
Thank you very much.
So when you give anticoagulants, okay, with colchicine, this not only blocks the factor 10A activation, but also the inducer of factor 10A. So we're blocking both. We're not blocking just the factor 10A. We are blocking the inducer, okay, of factor 10A. Thus, colchicine can prevent thrombosis if given as a prophylactic and is protective in infected individuals, as the virus induces tumor necrosis factor A alpha, which is A, which is also subdued by colchicine. So it works in many ways to stop that inflammation, to stop that clotting. All three of my lectures, this is my third one with Dr. Mobin, both the first one we're talking about clotting. And all my successes have been using, in the worst cases, using even things like low molecular weight heparin called enoxaparin, which has been very successful for me. I mean, it's been really my big go-to if the oxygen reading drops. So this is why I use colchicine. Next, I think we're almost done. Yeah. Now, what is the role of colchicine in prophylaxis? I mean, I prescribe colchicine for both, for general prophylaxis prior to the actual attack of COVID or the acute infection. But I've also started using colchicine now as a prophylaxis for vaccines. So I use it for 3 to 5 days before the vaccine, and I use it for 7 days after the vaccine to prevent any kind of a thrombosis that may happen induced by the vaccine. So I'm trying to cut down the side effects of vaccine down to almost zero. So far, fortunately, I've never had a major side effect. You do get fever, you do get an arm irritation, but you don't get the thrombosis or the clotting that you will get if it is going to mimic what the actual COVID virus does. Okay, Movin.
Got it. Thank you very much. So I think this is the mechanism of colchicine. So there was a question here. Texas Meg said, did you say what cytokine it works on, or in what part of the immunological cascade? Might have missed what the pharmacist said. So if I can go back to these slides for a second, Texas. So here, number one, on the tissue factors which are participating in clotting. In addition, colchicine is working with neutrophils. That is part of the innate arm. And then monocytes, these are also part of innate arm. And if I heard you correctly, Darrell, was this tumor necrosis factor alpha?
Yes, correct.
Perfect. So that answers that question. So once again, thank you very much for this. Anything more for colchicine? Any dose, any side effects you've seen? And once again, for the cool beans here, my apologies, Darrell. For the cool beans here, not a medical advice. This is just educational, informational. Most use will be for the healthcare workers who can understand how to use it for their patients. Yes, Darrell.
Yeah. So for me, I mean, in gout, we've used this from anywhere from 6 milligrams a day to 30 milligrams a day in the acute flare-ups of gout. Okay. So, but in COVID, I'd worked up to a maximum of 3. I'd actually titrated my dosages in the first 200 cases where I was looking at what is the most effective dosage for this. I've tried 0.5 milligram. I did 1 milligram. I did 1.5 milligram. I did 2 milligram. I went to 3 milligrams. what I found to succeed the most was the 1.5 milligram, where you use 2 tablets in the morning. We get 0.5 here, so 2 tablets in the morning after breakfast, half a tablet in the night after dinner. That seems to work the best. Now in the US, you get 0.6 milligrams. You may want to use 2 tablets of, so it'll be 1.2 in the morning and 0.6 in the evening. I've even done in people who I suspect to be more advanced, I do 1 milligram, both morning and evening, and they seem to recover. So it's about knowing, it's about titrating a dose to the patient's presentation. Listen to that history. Listen to what your patient tells you. It's pretty easy then this disease is an easy disease to treat. I've said this and said this and said this 1,000 times. This is, if you understand the mechanism of how the disease evolves over the 14 days, and you have the right tools in your armamentarium, in your pocket, what to use, which I have, you will have success. People don't have to die. And, you will still get some deaths, but those deaths are, if they're going to die, they're going to die, some people. But most often, you're going to make people who would normally die if you didn't intervene to help intervene with them and get them better here. So this is one of the reasons why. Talking about dosages. Now, the concern I have, and I've always had with colchicine, is the effect on the kidney. It is not processed in the liver, it's processed in the kidney. So anybody with a serum creatinine of higher than normal, I will titrate it down. Anybody on kidney failure on dialysis, I'll go with a 0.5 milligram tablet once every 2 days, given just after their dialysis. So 3 times a week. So I do a Monday, Wednesday, Friday, a Tuesday, Thursday, Saturday, depending on when they have the dialysis. I don't do the Sunday. I back off on the Sunday. So I give them time to recover. But it's been successful. And people with single kidneys, there are lots of people who have single kidneys or transplanted kidneys. You have to be careful and look after those that's kidney. You don't want the patient to lose that kidney. So I titrate my dosage down. I start up at 1.5 or 2, and 2 is the maximum I've used. Okay, but I go down then depending on the status of the kidney function. If the kidney function is not good, I will titrate it downwards. And if you have poor or inadequate kidney function, even a 0.5 milligram of colchicine will do wonders for that patient from a COVID perspective, because the amount in the blood is pretty high, and that's what you want. Okay, moving.
Got it. Thank you very much for this. So ready for some questions?
Sure.
Okay, so what we're going to do is we're going to go to Twitter first. And actually, can I ask you a question? Can I be cynical for a second? Because yes, I know that these are the comments, some of these comments will appear. So I'm going to just ask them on the not so happy cool beans. And that would be, isn't this the number of deaths or the number of cases less in India not really an sign that this is the success of colchicine or ivermectin or other medications? Instead, this is just maybe the regular viral cycles, or maybe India is just not reporting the data correctly.
I have no comments on the last part. I will not talk about the data reporting. These are daily new cases. I can tell you the daily new cases in most parts of India today are down. The total number is down to less than 25,000 cases a day. At that peak, we were talking about 500,000 cases a day. So we were looking at large numbers. Personally, I did 80 cases a day at the peak. 16th of April was my worst day. 1,400 calls. I missed 1,200 of those. I probably looked after 80 plus cases. I stopped even counting what exactly the number of cases that day. I didn't sleep. For many days in that period, we went with 4 hours, 3 hours, 4 hours, 5 hours of sleep. Got up in the morning and you worked the whole day. You caught a meal in between, snack, whatever you could get. But and that was our life at that time. But today it's been much more controlled. Today I do, like I said, 2 to 4 cases a day. Plus I do a lot of post-COVID cases. But again, the new cases have come down drastically. And
excellent.
It is whether the government controls, whether people have learned COVID-appropriate behavior. We've just had a festival called the Ganesha Chaturthi Festival. I was expecting to see a bump in cases yesterday, today, tomorrow. It hasn't happened. Okay, so I think from a wave 3 perspective for India, I think we will have, and I've said this long ago, way back in May or June, I've said wave 3 it'll be half of what the wave 2 was, or maybe even 1/4 of what the wave 2 was. We will have wave 3, 4, 5, 6 till the whole population gets COVID. Everybody's going to get COVID in the world, but it's going to be much less. And doctors have learned how to treat this disease. They've learned how to give something early, to give something on day 2, day 3, day 4, day 5. And that message has been hammered home, I think, by many of us in the fraternity. We've done videos, we've done Zoom calls, webinars, everything I've done to educate doctors how to treat these patients early. And I think we're seeing that now, where the amounts have come down pretty drastically. Mobin?
Got it. Thank you very much. My apologies for this question. I didn't mean to offend you, but I know that this question would have been asked. And to add my comment to that as well, look, if India was not correctly reporting, then they were reporting here at the peak as well. They were reporting here at the peak as well. Why would they now start to reduce reporting? So I don't think it is a reporting issue. I think, sorry, Darrell, you had a comment.
I was going to make a comment that I've actually made a prediction that the US is probably on the way down in the cases. And I predict that sometime mid-October, mid-November timeframe will also come down to a pretty low level in case. That's looking at the US cases today and looking at what a trend. I always look at trends. I think we are going to see the US cases come down pretty drastically after the 15th of October. We've got another month to go, but and that month can be brutal. But I think the US is also, we're getting up to that peak. It'll be less than the previous peak, but I think we will have the down leg pretty much in the next month. I expect the down leg to start, and then by mid-November it'll be probably down to almost, I won't say zero, but it'll be 25,000, 50,000, 40,000 cases a day. I mean, that's what you're going to have. Moment. That's a prediction.
And your prediction is based on observation for the cycles, virus behavior, people behavior, medication, vaccination, combination?
It's a combination of everything. It's people behavior, virus behavior, because these viruses are less potent. I mean, in virology, we all know when you have a mutated virus, it's going to be less lethal, less potent, less virulent. It cannot be more lethal. Okay. So that concept, people have, I keep hearing about saying, oh no, Delta is really worse than the early one. No, sir, it's not. People sit on their disease. They sit on their symptoms. They don't come to hospital. They don't report that they have a problem. That's what kills them. You lose. So when I talk to people in the US, I always say, add 4 days. If the patient presents with fever of 3 days duration, add 4 days and treat him like a 7 or 8 day 8th case. If you treat that way, you will succeed. So that's what people like me were doing here. I started adding when it was Delta. We had Delta here starting, I think, November or December. But in the peak, when we were talking of February, March and April, I would just add 4 days. If somebody came to me with history of fever of 3-day duration, and his oxygen reading was in the 80s, low 80s, high 80s, didn't matter. I treat him like a day 8 and then start the treatment for day 8. So that's how I took it. I think the US doctors will also start doing the same thing about adding the 4 days to it, to whatever history the patient has, and then treating it as the advanced case rather than as the early case. So that's my view of it.
Got it. Thank you very much. So I'm going to now go through the questions. So here is the tweet I had about you and you joining us. And here are some questions. So I'm going to...
I love the one about mellow yellow. I used to like it, but I haven't had it in a long time. Yeah. Thank you, Dr. Yo.
So Dr. Yo, a quick history about him. Dr. Yo is a good friend of mine. He is actually a class fellow, I believe, or a session mate of our medical director, Dr. Ahmad Zafran. They both used to be together, studying together. Dr. Yo is now working in New York. So Dr. Yo's question, and he always usually comes in, trolls people, asks them their spirit animal and so on. Here is his question. I love Dr. Yo. He's saying, is it true that Dr. DeMello's favorite soda is the original smooth mellow yellow?
I've tasted it. I've liked it. I can't have any bad comments to it. But I'm not a soda guy. I'm a water guy. I have not had soda in a long, long time, and I'm pretty clear about that. From a health perspective, I've been pretty much on the wellness side of life. So that's me. Okay.
Got it.
Yeah.
Got it. So Dr. you got your answer, right? So let's move on. Next question is from Jean M. Oliveira. She's also a great cool bean. Old family recipe, perhaps. So could you share any nice family recipe? Only being playful. Highest regards for you, Dr. Bean and Dr. DeMello, the best of the best. Next question, I hope, is from Jean Currenson. Question: many countries have adopted the wait and see approach. Therapeutic nihilism. When a patient first is diagnosed with COVID-19, how important is early treatment?
Early treatment is the bottom line, is the foundation of the success of those numbers you saw. Last year in May, I was one of the only people doing early treatment in India. Most of the doctors were saying, take your paracetamol, take your vitamins, and wait. Go sit in hospital or sit at home and wait. No, I started treating from day one. The day one or day two or day three, the patient came to me, I started treating. Okay, so the early treatment has borne it out that if you treat early, you can, and if you saw that Colchicine slides, you can stop that progression to thrombosis. If you stop the progression to thrombosis, you stop the clotting of the lungs, you stop the microvascular clotting in the brain, in the heart, and everywhere else, and you stop death. That's the bottom line. So early treatment with a thing like Colchicine, with whatever drugs you use, please do it. Okay? Make sense?
Absolutely. Thank you very much. I'm going to mix in some YouTube questions as well. And really, Darrell, those patients who have you as a doctor, they are lucky. So here, Zan Solo says, Dr. DeMello, what about amino acid lysine for COVID treatment and prevention? There are statements that with lysine, there would be no need for vaccines.
Zain, I picked a group of drugs. I stay with it. I don't try and chop and change. I try and stay with the package of drugs I use. I'm very comfortable with the effects. I'm very comfortable with the side effects. I know what to expect. I do not try and change it because this disease, when you're in the peak of the disease and you're in the midst of people dying, if you try and chop and change, you're going to lose the more patients. And my death rate has been so low for the numbers I've done. My admission rate is extremely low because I do early treatment, because I stop this. And I think I've got the right recipe of success for treating this disease, which is using Colchicine as my baseline anti-inflammatory, using Ivermectin as the baseline drug to prevent the replication of the virus, using a drug called clopidogrel, which is Plavix in the US. I use that for preventing the adhesion of platelets. It's an antiplatelet agent. And then I use diclofenac. I don't use ibuprofen. I banned ibuprofen for my practice for a long time. Since COVID started in February last year, I stopped using ibuprofen in any of my practice. I use diclofenac. With diclofenac, I can take care of the peripheral inflammation. I also use cetirizine, which is an anti-allergy drug to prevent what's called mast cell activation syndrome. So there's a lot of thought that's gone into why I put that package together. I will use other drugs. I use enoxaparin, which is a low molecular weight heparin injection. I'll use that when a patient comes to me with very advanced COVID, and day 8, 9, or 10, oximeter readings anywhere from 60 to 90. I will use steroids if I have to use steroids, and I don't care what steroid is used. Use some steroid at that stage. So there are other things I use. So it's not just one drug or one thing. This is the success that I've had is because I've had a combination. I've had a cocktail of drugs. I've had probably the right combination to go with it. Make sense, guys?
Absolutely. And for the cool beans who may be thinking about the combination, there have been other talks by Dr. Darrell DeMello on our channel, so you can watch those talks too. Today, we wanted to focus on how to manage during the disease with Colchicine, and secondly, your questions. Here is a question from Darlene X. Can you get colchicine over the counter?
In India, yes. If I write a prescription, I can just write it even on a WhatsApp message. They go to the chemist, they will get it. But I do not know about the US. So I'm not going to comment on whether you get it over the counter or not over the counter in the US. That's not my role. So I can't give you any kind of a indication. My thought process, you still need to go to a doctor to get a prescription for it. So that's.
I think that is how it is. I don't practice in the US, so I would not be able to say it for sure as well. But I think even in the US, you have to go to a doctor for the prescription. In Pakistan, I believe when I ask patients, and Darrell, I have listened to this from you and then started using it, and that is over the counter over there.
Mm-hmm.
So your impact, your positive, contribution is expanding. Thrill 0415 says, are Eliquis blood thinner or K2 comparable to colchicine for dissolving coronavirus clots?
The short answer is no. The long answer would be colchicine starts acting on the microtubules, on the monocytes, on the macrophages way in advance of clotting. Eliquis is trying to stop that clotting when it's far advanced. So there's a difference in that. Okay, so if I use Eliquis, I'd use it instead of clopidogrel, instead of Plavix. I would not use the Eliquis instead of colchicine. So that's the difference in what I'm trying to say. Make sense?
Got it. Thank you very much. Yes, it does. Lisa says, listening now, such terrific info. So Lisa, thank you very much for being live right now. Little Guys SOS says, I'm so glad you asked. So I had requested if you have any questions. Can Dr. DeMello grab the bull by the horns on colchicine and discuss the clinical trials, talk about drug interactions with Ivermectin? Can they be taken together at lower doses?
I'm not going to discuss clinical trials. I'm not come prepared to talk about the clinical trials. There's been a trial called the Colchicine study, which I think Dr. Drbeen has already gone through, and you went through it pretty much in detail. I didn't even know there was a trial called Colchicine starting, other than I would have contributed to the thing when we first started it. But I've been using colchicine from day one. We're talking about when I started treating in May 1 or May 2. Last year, 2020, I started treating. I used colchicine as my baseline anti-inflammatory drug. Okay, drug interaction with Ivermectin at the dose I use, I think there's no drug interaction. I've never seen it. I use also a low dose Ivermectin. I don't use the high dose Ivermectin. I use it 12 milligrams and 12 milligrams twice a day for 2 days only, and it's out for me. Okay. So can they be taken together? Low dose, absolutely, they can be taken together. I have no problems. I've had no problems with any of my patients. People have said, aren't you worried about diarrhea? Aren't you worried about agranulocytosis? Yes, if I was using 10 milligrams per day or 30 milligrams per day, I would be worried. At 1.5 milligrams or 2 milligrams, that is really, really low dosage. Okay, so I hope that's your answer for you. Little Guys SOS. Okay.
Thank you very much. So again, the focus today is colchicine COVID management. So I would try to keep the questions in that as well. For example, Diane, you have a question about plasma therapy. This may not be relevant to today's topic.
It doesn't work. It doesn't work. I just say move on from plasma. We've said it never worked, and still it does not work. And people still use it, and it doesn't work. Okay.
Got it. Thank you very much. So Lynn Scott says colchicine is by prescription only in the US, but it's cheap, at least for gout. So it is used for gout with the prescription. Okay, so
Zara
sorry, go ahead.
Is there a test to determine if a person is susceptible to myocarditis? I don't know about a test. What I do is I'm now at a stage where I just prevent. I believe in preventing rather than treating. So I don't want somebody getting myocarditis. I just give them the colchicine as a prophylaxis and continue after the vaccine and move on. I'm not going to even worry about myocarditis. Fortunately, I've had great success with that. Okay.
Got it. So Zahar Lawati, I hope that answers your question. Augie says, any success with long haul greater than 12 months?
I've had 2 or 3 patients. I've had very small numbers, so I can't give you an answer whether it succeeds or not. Okay, so I'm hoping it does. Theoretically, it should, but again, long haul. Remember, long haul is 12 months and more. Those nerves you're looking at, which are they've already had their microvascular circulation impaired with microvascular clotting. Those nerves may not be in the best of frame to recover fully. Those nerve endings from head to toe. Okay, so long haul is the anybody with constitutional COVID will end up or could potentially end up with long haul COVID. So that's why giving colchicine early will prevent that. But the question is, will it help somebody beyond 12 months? I don't know. I'm trying. If I get more than 12-month patient, I will try it. I'll give colchicine. I'll probably give a short dose of short-term course of low-dose dexamethasone. But again, I will do whatever the patient's needs are, and colchicine becomes the base. But again, I have no experience on that. Okay.
Got it. Thank you very much. Mark Zapp says, do you think the current leaky vaccines propagate more virulent viruses? Should anyone not immunocompromised receive a third wild-type vaccine? Is it best to just get infected after vaccination and then treat with antiviral or better immunity?
I'm not even telling you to treat with antivirals. I'm going to tell you to treat with colchicine and anti-inflammatory. Stop that tsunami. Stop the bad effects of the tsunami. Let the virus come and eat and come into your body. Your body won't react. I had asymptomatic COVID. I've been on colchicine since April 1 last year. Okay, 0.5 milligrams a day. So for me, it's about stop the body from exploding into flames. If you can stop your body from exploding into flames, whether the virus comes to you or not, whether you get the vaccine or not, it doesn't matter. Your body won't get fired up. Okay, so if you have a good fire retardant in your body, in your home, you will not need to do anything else. I mean, those are my views. Okay.
Got it. Thank you very much. And I want to clarify, Mark, do you think that the current leaky vaccines propagate more virulent viruses? There is no such thing. Neither has this been proved that these vaccines are leaky. These are rumors and myths created by some of the doctors, which they should not have. Leaky vaccines have been a theory that was proved in some chicken virus vaccines, and they have never been proved in humans, especially for SARS-CoV-2, even when they try to create them in a clinical in vitro setting, not clinical setting. That's one. Number two, vaccines do not generate virulence or viruses. Please look at nextstrain.org. I have been looking at that site, I think, for more than a year with cool beans. And we have always been seeing that there are strains that are, and variants, that are coming up. It is not a new thing that this is happening, and this is not the vaccines that are causing this. The reason I'm talking about this is that these are strange discourses that have been added. And now we can't even talk about vaccines efficacy or not efficacy or side effect or not, because there are so much such things that have been added. And finally, should anyone not immunocompromised receive a third wild-type vaccine? Boosters, we'll have to figure out how they go. Israel has shown some booster data that has been useful. Now, does everybody need booster or not? I don't know. It is interesting today. Today is Friday, September 17th, 2021. Today, FDA panel is sitting and discussing the need for boosters and approval for boosters. I'm worried that they would, if they come out and they say now the vaccine passport will mean you need to have a booster as well, that worries me. But still, we'll see what data they have. So I just wanted to make sure that we ground ourselves as well. Vaccines have their own pros and cons, but the concept of creating variants is wrong. Sorry, back to you, Darrell. Next question here. Did you use fenofibrates for treating COVID-19? Data from Israel looks quite interesting, also to fight severe disease.
As an early treatment, the answer is no. But if somebody was on a fenofibrate, I would just say continue your fenofibrate, because I was not going to change the drugs that they were already on. but I was not going to. I have my set of drugs that I use. I've said it all year long, all year and a half. I've said it that these are the drugs I use. I've been very successful with this package of drugs, this cocktail of drugs. I've not tried to try everything else. I've been pretty conservative in how I approach this. Okay.
Got it. So some questions from the YouTube side. Eric Dog says, does India give vaccine to 12 years old?
No. No.
Thank you. Soma and Sejoy Ghosh says, what about millions who get isolated and become negative without any meds here in India? Any clotting issues for them in long term?
We don't know, but some of them, I mean, today we don't know, but some of them could come back with not only clotting issues, they could come back with brain fog, they could come back with tiredness, they could come back with lots of issues. I just had a couple who sat with me this evening here where I'm sitting. They sat with me and they told me about how he can, even 3 months and 4 months after his COVID, 3 months, I think it's 4 months now after the COVID, he cannot exercise. He feels very fatigued. Even the mildest of exercise, he feels fatigued. So I put him on treatment, back on treatment with Colchicine. She had a different problem. She had pain in the breasts. It wasn't, I mean, my view, it's not breast pain. It's probably the nerve endings which are inflamed in the muscle tissue under the breast, which are causing her, and misfiring, which are causing her the problem. So I ended up putting her also on Colchicine. So that's the way I work. I mean, I have to understand the root cause of the whole thing. If you know the root cause, you can actually treat pretty well. Mobin?
Thank you very much. Nice try. Listen to the scientists who were involved. And Darrell, I will respond to this because it is in response to my comments. Involved in the technology, stop comparing these shots to regular vaccine. Nice try. You said up here as well that somehow the vaccines, when you administer a so-called vaccine while a virus is active, it causes pressure. This is just incorrect mechanism. So either we talk with some correct mechanisms. These are myths and rumors, and I do not know why we keep coming up with these. These are myths. One has to have a mechanism for this. So my request to you, Nice Try, would be to find a mechanism for how that would happen, and then we can discuss that mechanism. Okay, so continuing. Nicole Kelly says, is there always clotting issues? Do we always need a blood thinner?
Again, let us differentiate between a blood thinner and an antiplatelet agent. Okay, Colchicine is not a blood thinner. It is a anti-inflammatory drug which prevents clotting. Anti-platelet agent is an agent that will prevent the platelets from adhering to each other and causing clotting. A blood thinner is like an aspirin. An aspirin will thin your blood without impeding the platelets, the combination of the platelets, or the factor 10A activation of the thrombosis of the coagulation factor, the coagulation cascade. Okay, so we have to differentiate these three. If we don't differentiate it, we talk of everything being a blood thinner. No, it's not. So I mean, that's my perspective. Mobin?
Got it. Thank you very much. Augie says, have any colleagues or hospitals implemented your protocols?
A lot of colleagues. I mean, a lot of doctors. I've seen the best accolade you can get is copycat prescriptions, and I've seen Colchicine, basically the same drugs I use. I've seen it being used, so I'm very happy. I'm not worried, because I'd rather have people use the same thing and have success with it than say no, this is only mine and not. I mean, I'm here to share the experience I've had, help people learn, help people treat with the drug package I use to treat the patient correctly. Mobin? Got
it. Thank you very much. Korotika says, Dr. Bean, why do the vaccines not elicit mucosal IgA production? So, Darrell, are you okay if I took it addressed to me?
Go ahead.
So, vaccines do produce mucosal IgA. It is interesting in our body when an infection occurs, the site of infection and the type of site kind of causes the immune system to lean towards a more concentration of a type of vaccine or antibody or not. For example, respiratory infections, they lean towards producing more IgA. So when a vaccine is given intramuscularly, it may produce slightly fractionally less IgA, but whenever immune system attacks a pathogen or an antigen from outside, it produces IgM first, then it switches over to producing IgG, then it produces other antibodies too, including IgA. Our body knows to protect all of its areas. So vaccines do produce IgA. I think if your question is under this context, that if vaccines were protecting our mouth and nose and eyes, then why can we get reinfected? The answer to that is very simple. When the antibodies are being produced and they are actively being produced, our chances of getting reinfected will be less, even if we are exposed. But once the antibodies wane, which is part of the normal immune behavior, then we become a little more prone to getting the virus in our mouth and duplicating. Sorry, so going to continue with the question. So here, if we go to, I'm going to see on the Twitter side, Joel, are there any good resources, clinical trials we would provide to our PCP to explore colchicine for vaccine side effects prevention? Sorry, that was so any, do we have any literature, anything that can be shown to say, here is how colchicine works, or any studies, trials?
The Colchicine study has been the only study done on colchicine in COVID. And I don't think there's any other study been done. And I can't think of anything else that has been done, And as a single practitioner, it's impossible for me to do a clinical trial. Even though I've had a ton of cases, it's impossible to do a clinical trial. Mobin?
Got it. Thank you very much. John Miller says, Dr. DeMello, have you had any severe COVID cases, hospitalizations, or deaths in patients with a vitamin D level of 60 nanogram per milliliter or higher? Looking at the studies, and almost no cases above 60 nanogram per milliliter.
The answer to the first part is no. Every patient who died has had vitamin D of probably less than 10 or less than 20. Okay. Above 60, the reason why I sort of hung in at 60, because I started seeing that if you had high enough vitamin D, you were more or less either asymptomatic or very mildly symptomatic. And that's the bottom line of why I went with 60 and above. Okay. Normally people say even 40 is normal, is okay. But for COVID in particular, I've been hammering home this point that your vitamin D has to be above 60 and less than 100. You don't want to be in toxic territory. But if you're above 60, you have a better chance. You have a great chance of getting mildly symptomatic or asymptomatic COVID. Okay, and I'm a living example of that. I've had COVID the asymptomatic way. I didn't know when I had it. I've seen patients. I've continued seeing patients all through the lockdowns, all through the year and a half, and I've never hesitated to see a patient face to face. Okay.
Got it. Thank you. On Twitter, there's a question by A. Lafferty. He or she says, can colchicine help with interstitial cystitis? So it's a different topic. A bit off topic, but COVID made my interstitial cystitis worse.
I don't have a comment on that because I have not had that experience. So it's difficult for me to make that comment. And I'm not going to speculate also on it.
Got it. Thank you. How is the only way to reach, so this is Bethany Sheris, how is the only way to reach herd immunity through a vaccine that doesn't provide immunity? So I think, explain it to me like I'm too, so I think this is not a relevant
The
question.
only way to reach herd immunity, and herd immunity is defined as 80% or 90% of the population getting COVID, is the natural infection. You want everything possible to reduce the severity of disease. Vaccines are supposed to reduce the severity of disease. Vitamin D is supposed to reduce the severity of disease. Colchicine is supposed to reduce the severity of disease. So I'm giving you everything that you need. And if you combine all of it, herd immunity will happen over time. The whole world will get COVID someday in the next 2-3 years. The whole world will get COVID. You can hide. You can't run away from COVID. You will get it. Sometime you'll get it. So you want to give your body a good, healthy body to be able to take on COVID, rather than a weak body or an immune compromised body or a diabetic body where you have a problem. Okay?
Got it. Thank you very much. So I think the questions on that side are finished. So we saw Robert Malone's tweet that was just below my tweet. So continuing, do you have some more time for the YouTube side?
Sure, that's all.
Okay. T. Hunter says, based on your answer to another question, do people with natural infection have a greater production of IgA than those with vaccine-induced antibodies? It may be directed at me because I talked about IgA. Do you want to take it, or should I?
You take a moment. There's no problem.
Yeah, so T. Hunter, ideally, a respiratory infection itself would create more IgAs, plus it would create more immune cells that are on the lining of the respiratory mucosa to be more in number and be memory cells and so on over there. But once again, I think you and I both know, you are a cool bean here for a long time. Infection is dangerous with COVID, and it is deadly. So because of that, the second best is vaccines, and then the medicines, as we are discussing. But from a mechanism point of view, you're correct. So Timo says, is quercetin still relevant to treat COVID? Do you use quercetin in your?
No, I don't. I've never used quercetin. And again, that's why I try to differentiate between quercetin and colchicine. Two different drugs. I've never used quercetin. I've been pretty successful with what I use. I'm going to stay with what I have.
Got it.
Okay.
Trijoy, you have a question which is a personal medical advice. And so I can't use that question to get you an answer. My apologies. Rob says, how can the messenger RNA vaccine produce the same antibodies as the infection with the virus does?
The mRNA vaccine produces antibodies to the spike protein. They're all built against the spike protein. The natural infection produces natural immunity, or natural immunity comes from natural infection. And that, to me, is really the actual immunity that you should have. And that's why I keep saying everybody will get it. But the vaccines are supposed to reduce the severity of disease. That's the whole thing. They're not here. The vaccines have never, at least I've never told people, the vaccines will make you immune to getting COVID. You will not. I always joke with people, you don't become Superman and fly off a building, jump off a building because you had 2 vaccines. You are still liable to get COVID. We do not know to what extent that severity will happen or be reduced. Until we know that, I can't give you an answer. So take your COVID appropriate behavior steps. Follow your social distancing, washing your hands, wearing your mask. All those steps, please follow, because you are going to get COVID someday. Everybody who hasn't had COVID is going to get COVID someday. Now, on the reinfection, let me go back to the study out of Milan or Lombardy province, which talked about a reinfection rate from their study of 1 in 100,000. That's as good as 0. And I keep telling people that's a rounding error. So in my perspective, I don't think we're going to have reinfections. Whether it's 2 years or 5 years, I'm more towards the SARS side of things and not towards the flu virus type of reinfection. I do expect to have reinfection. Whether it's 2 years, 5 years, or 10 years, I don't know. Time will tell. Owen?
Got it. Thank you very much. 3 important questions, and maybe we take them as last questions. Number 1, do you have a protocol listed on different stages to follow?
I've not listed my protocol anyway. Yeah, there's a protocol listed on some of the websites in the US, but again, that's a suggested protocol. I do not list my protocols officially. I do not provide advice to people in the US or anywhere else. I make suggestions. Whether you follow it, whether your doctor your doctors, your PCPs, your treating doctors follow it, that's up to them. But this is my experience. In India, I actually share my protocol with other people. I talk on Zoom calls and webinars and all. I do regular webinars, and I'm willing to share my experience with people to make sure that they are treating right, and it's happening.
Got it. Thank you very much. JH says, does Dr. DeMello use antihistamines for COVID?
Yes, I've used antihistamines. I've used cetirizine more than anything else. I think in most cases I've used cetirizine. I've not used promethazine. I don't use the other newer levocetirizine. I don't use that. I use cetirizine, basic cetirizine, and as part of my 5-drug protocol if I have to. Okay.
Got it. Thank you. So one last question. John Titer says, Dr. DeMello, have you treated individuals with long-lasting post-vaccine side effects like neurological fatigue issues using colchicine?
Again, depending on what is long-lasting. Here, we had vaccination start in January, towards the end of January. And that was restricted to healthcare workers, doctors and healthcare workers. The general population got to use the vaccine only in April. So April to September, it's relatively new. I mean, so it's not long-lasting. 3 months, 4 months is the longest I think we've had. I do have people who had problems with the vaccine, having taken it in June or July. I've had people come to me with various issues, and I do treat them as post-vaccine events. I treat them with colchicine. I sometimes will add dexamethasone to combine it with colchicine to try and lessen or reduce the inflammation, and then keep them on colchicine for a longer time. But I'm not going to shy away from treating post-vaccine issues. There's nothing called getting away and saying no, this is a mental issue. There's no mental issue. There are post-COVID issues. There are post-vaccine issues. Let's recognize it as doctors and make sure we treat it in time. Okay.
Got it. So with this, thank you very much, Darrell, for being with us. Your insights, your own practice's success, the general situation in India that I'm sure that many doctors, as you said, have learned how to manage this, early aggressive treatment, combination. Now there are so many things that are available. Vaccines are available, medicines are available, social behavior is now enriched in our lives as well. Good or bad, that's a different thing, but we have to protect ourselves. So thank you very much for breaking the ground on this and for sharing your experience. Thank you for being with us.
Thank you, Mobin. I will go back to my pet theory. Get your vitamin D up. I think in India, people have learned that the hard way. They've brought up their vitamin D, and that may be also one of the reasons why we had the drop off the cliff in cases. The vitamin D in our population here is probably used to be pathetic. I think with aggressive vitamin D therapy, people have now recovered and brought their levels up to 40, 50, 60, 70. I have always maintained mine in the 90s, but I think vitamin D is could be one of the factors of why India has kind of fallen off a cliff from the case perspective. And the US will also benefit from that. Okay.
Got it. Thank you very much. And Cool Beans, so we would not do an evening session today. We'll meet again on Monday. One more request. YouTube has given me a strike yesterday for Dr. Pierre Corey's talk about managing COVID. So that means this talk could actually end up in a similar bucket as well. And after 3 strikes, they might bring the channel down as well. I think that's what I heard. So my request is that if this is useful, maybe download it, maybe share it, or make your notes from it. I do not know if it would stay up, and I do not know if the channel would stay up for long as well. So with this, Darrell, once again, thank you very much for being here.
Mobin, I think we have not gone into anything controversial.
I don't think so.
I'm sharing my experiences with treating patients. I don't think we have gone into anything controversial. And this is the way I work. This is the reason of my success I've had, and it's up to people to learn from it or not learn from it. It doesn't matter to me.
Yeah, absolutely. Okay. And I think it's just at this time, the focus on YouTube-like platforms is to continue to push for vaccines and anything that might help with COVID patients. There are just pressure on that. So with this, thank you very much, Cool Beans. Please like, subscribe, and share. And if you wanted to support this work as well, there are some links you can support them, support the work too. Darrell, once again, thank you very much and have a nice weekend.
Thank you. And thanks to all the cool beans. Have a great day. Have a great rest of the day. Thank you, guys.